And we're now live. You're on mute.
Dr. Williams, could you pull up the PowerPoint? Good evening, everyone. Welcome back to another episode of Corona Conversations, in which you have both myself and Dr. Maya Williams co-hosting, and we have an esteemed panel tonight. So we are here to talk about vaccines one last time. Perfect. This is our third conversation. And I guess, of course, we have our usual hosts, Dr. Maya Williams and myself. Next slide. So where are we? So most recently, we can see that we have over 42 million cases of COVID in the United States, and we are almost at 700,000 total deaths, unfortunately. Next slide. And in terms of vaccinations, we see that roughly almost 500 million people 500 million doses have been delivered and nearly 400 million have been administered. Roughly 182.6 million people have been completely vaccinated here in the United States. Next slide. And we have seen several things have taken place in the news in regards to vaccines. So the FDA has now approved that people who are over 65 or people with immunocompromised disease states or cancer or with solid organ transplant should receive a booster shot if they've gotten Pfizer. There's also the potential that children who are ages 5 to 11 may be eligible sooner for a vaccine, as Pfizer has shown data that the vaccine is safe in kids in that age group, but the FDA still has not approved that. So something to look forward to. Johnson & Johnson has been boasting the fact that with their booster, their efficacy can raise to almost 90-something% if you get a second shot. And also something that for those of us who like to travel or can look forward to is that there may be some relaxation to travel for people who are vaccinated who are coming from foreign countries. Next slide. But unfortunately, there are some disparities in people who are being vaccinated. There was also recently an article in JAMA that showed that there were issues with access to care in people who live in Black and brown people who live in those types of communities. Also, as you can see here, when we look at the people who received that first dose of vaccines, it's roughly 60% Caucasian. And I can say from personal experience that I had patients who were going to neighborhoods of the Black and brown, and they were actually getting vaccinated there, even though they were not the areas in which they lived in. And even though New York City was purposely trying to target communities of color, so it's not surprising that these numbers are so greatly skewed. Next slide. And here is another article, which has really shown some of the different reasons why we have disparities in vaccination rates, including economics, education, healthcare access, neighborhoods, social and community, as well as the fact that we know that unfortunately there's a big gap in between the median income of people of color as in comparison to our white counterparts. We also know that there are education disparities, as well as the rates of cases are much higher in our communities, but we also have fewer facilities. One of the privileges we had in our health system was that several hospitals were involved in some of the early drug studies of a drug called remdesivir, for example. And if you live in neighborhoods where you don't have access to that, then you are more likely to have less of the standard of care. Next slide. Yes, and then some of the disparities in terms of access and coverage were not only seen in urban areas, but they were also seen in rural areas just the same. So people who live in the country, as opposed to just in the cities, were also having issues getting access to care. You can see that actually living in the city, you're more likely to get vaccinated than if you do live in rural areas. And then, of course, this was another article right here that was published in JAMA, in which they did an assessment and they found that in a place such as Brooklyn, where you do have a diverse smattering of people, there were more vaccines in certain districts. And that was specifically going to be in districts of people that were of the majority race. And you can see here in District 16, where there were actually no sites for vaccinations as compared to like District 1. And unfortunately, you can see there was a good number of testing, but there was not a good number of vaccination. And then, of course, there are all types of myths. As a physician, I hear them all. Of course, Nicki Minaj has made a lot of doctors, including Dr. Fauci, quite upset with this tweet in which she said that she was not going to take the vaccine, so she would not make it to the Met Ball because of the fact that her cousin's friend was impotent after getting the vaccine, and his lady friend called off the wedding. So she was going to decline the vaccine, which meant that she could not go to the Met Gala. We also know that there's been an incorrect use of ivermectin. So ivermectin is a drug that's used to kill parasite infections. But what's happening is people are using it at doses which are much more higher than they should be used. That's been used as a tranquilizer or medication for animals. And they've actually been coming to the hospital due to ivermectin overdose. And we also know that there's a lot of conspiracy theories. And I can tell you that our Board of Internal Medicine has actually put out a statement that doctors who are pushing these conspiracy theories and this quote unquote fake news will actually lose their license. And that is starting to happen, where doctors are being held responsible for transmitting proper news about the vaccine. Next slide. But on a high note, we do see that even though there's a narrative being told that Black and Latinos are hesitant about getting the vaccine, we can see that these numbers have definitely gone up over time. Unfortunately, a lot of us are familiar with someone, whether it's a friend or a loved one, who we've lost to this disease. And in many cases, that has definitely driven us to want to get vaccinated. So it is not only a matter of the Black and brown people not getting vaccines, there are also people of other ethnic groups, as you can see here. Nobody is at 100%. So we should not be victim blaming only Black and brown folks. Next. And of course, community outreach is very big in all this. So you know what? These are some of the articles that have highlighted some of the things that we can do in the communities. I can say at Northwell, one of the things our community group has done is going to Western Beef on Fridays when people are often shopping, because that's around the time that they're getting their paycheck, and vaccinating people there. And they've actually been able to do a good job of vaccinating some Black and brown folks that live in that area. Next. And then of course, if you're still unvaccinated, vaccine access is so much better than it was in the beginning. You can always go on the website nyc.org, COVID vaccine finder, or also our Northwell page, northwell.edu. You can schedule your vaccine. For those of you who qualify for a booster, you can also use these sites to actually register. Also, many neighborhood and chain retail pharmacies, you can access their website. And a lot of them nowadays, you can actually walk in and get a vaccine off the street. And most of them actually will post whether they have Moderna, Pfizer, or J&J. Next. And as usual, we like to thank our community sponsor, BC Kathy Cares. We also would like to thank Mr. Courtney Tisson, Mrs. Kathleen Guyan, who is the founder of BC Kathy Cares, Miss Louisa Wilson, Jared Oliveira, and Richard La Rochelle for constantly pressing on these communications to throughout Northwell, as well as one of our other community people from Northwell, Miss Josephine Guzman. Of course, our day one audience members. Please don't forget to follow us on both Twitter at the handle at Minority Health 3, and also on Instagram. Our handle is minorityhealth.combos. So now for our esteemed panel. First and foremost, we have Mr. Mitchell Cornett, who is the Vice President of Community Vaccines and Public Health at Northwell Health. We also have Dr. Favel El Mondesir, who is a postdoctoral research fellow in epidemiology at Boston University. And last but not least, we have Dr. Adjua Smalls-Manti, who has done a lot of work around HIV and vaccines. And she's currently she was a chief resident during her training, and she's currently an emergency department psychiatrist at New York Presbyterian, Columbia University, Irving Medical Center, as well as NYP Brooklyn Methodist Hospital. Thank you, and I will now turn it over to my colleague, Dr. Williams.
Thank you very much, Dr. Myers. Give me like 2 minutes to pull up the questions.
Yes. There's so many questions that people have. about
Right.
this vaccine, because we have a healthcare mandate coming out next week where people are possibly getting pink slips. So this is a hot topic for sure, Dr. Williams, because I actually had to say goodbye to some people today in my office. I
Yes.
tried. I really tried, but there was a few that just refused. I was able to help some, but there was one that I said goodbye to, and it was really unfortunate. I don't know how or where she'll get another job, but I wish her the best. But it's actually going to be a big loss for a lot of health systems that we're going to lose people who just don't want to get vaccinated at this point. Yeah, Tuesday
Right.
soon come. You good?
Yes, so I guess I'll start with this question because I believe that our health system also sent out correspondence a couple of days ago about individuals who, if they were not vaccinated, then there was a state mandate about all healthcare employees needed to get vaccinated. And so this question is for Mr. Mitch. So President Biden announced that all employees with more than 100 employees will be forced to either require their employees to get vaccinated against COVID-19 or mandate weekly testing for the virus. Furthermore, the remaining 17 million healthcare workers employed in facilities that receive federal medical care or Medicaid will also have to be vaccinated. Together, the two groups represent about 100 million Americans. How should organizations, managers, co-workers be approaching and handling conversations around COVID-19 vaccine for those who are still unvaccinated? And what are the repercussions for employees who are not vaccinated?
I'm not gonna, I really can't speak about other organizations. So what I'll do is kind of just focus on Northwell, as that's where I really have more of the experience. From our perspective, all of our employees, we've had discussions regarding the vaccines. I mean, one of the things that we have tried to do is to make sure that all of our team members understand the mandate and what the mandate actually means. And through that, we're hoping that we can educate them to give them sort of an understanding of why we need to move forward with them getting vaccinated. However, that is sort of the starting point, is what I would say. From the perspective of us as an organization, our senior leaders have already spent time with all of the team members who are in departments with low vaccination rates. One is to kind of, again, have that communication with them and discussion regarding the mandates and what the importance of getting vaccinated. But in addition to that, to give them an opportunity to kind of explain their concerns. We also look to participate in discussions via, for example, focus groups to kind of understand in more depth the concerns that our team members are having as it relates to getting vaccinated. And we take from those focus groups, a strategy of education so that we can help eliminate some of the misinformation that is being spread out regarding the vaccine, and also gives us an opportunity to take some of our experts that we have working in our health system to provide detailed, clear, clinical, scientific education as it relates to the importance of getting the vaccine. In addition to that, we provide multiple avenues for our team members to get vaccinated so that they don't have to necessarily just get it at our emergency employee health services, but they can also get it out in the community and just provide us proof of vaccination. We have a process for medical and religious exemptions with a complete evaluation of the request. And I think the other piece of it that I think is critically important is the fact that our senior leadership, all the way up to our president and CEO, our executive vice president, chief operating officer, actually have town halls where our employees are given the opportunity to ask questions about the mandate, and they are as truthful as possible in explaining and answering those questions. So that's what we do to support our team members as it relates to the mandate.
Thank you very much. And that drives me into my next question, which is for Dr. Smalls, that at the beginning of the pandemic, or initially when there was the vaccine rolled out, we saw a lot of incentives coming out. And yet still, it feels like these incentives do not do much. They didn't push the rates. Well, initially they started pushing the rates of the vaccine slightly up, but then that just stagnated. And you recently wrote an article where you were talking about incentives are not the only thing that could raise the vaccine rates, but there are other things that could happen. So why were vaccine incentives unable to raise vaccination rates to the level that public officials hoped? And what could work to get people vaccinated?
I think there are many reasons why they were not effective. For some people, they didn't know about them. I think that was a big problem that I saw, particularly in New York. If you were paying attention, you knew, but just walking on the street or something like that, you didn't necessarily know. It wasn't a part of any commercials. So people didn't know about the incentives. For the other people, maybe there is a lack of convenience for even getting the vaccines. Like if you know you'll get, let's say, a free coffee if you go to Starbucks and get the vaccine and it's right there, maybe that'll work. And maybe that little incentive, hey, a $25 gift card would be enough. It's right there, it's convenient. But a lot of the vaccines didn't match a convenience model. And there was just a lack of urgency at that time to a certain extent. But what has worked is we saw that the lowest rate of vaccination occurred in July. We were down to about almost 400,000 vaccines at that time. And then at the end of July, COVID started going up, more so in the southern states. And then the vaccination started to rise and peaked at 4 million vaccines, and started going up. So I think with more of the threat, people decided, hey, let me go get the vaccination rate, because now they are seeing the worst of COVID that we saw here in New York and other regions last spring. Another thing is the mandates. They do work. I know a couple of people said I won't get it until my job tells me, and many of us can think about the flu vaccine, like how many of us got the flu vaccine until we had to get it for work, or various vaccines until you had to get it to live in a college dorm. So, a lot of, even vaccines for children, until the United States really started enforcing and mandating it in the 70s and 80s, our vaccination rates for a lot of diseases weren't very high. So the vaccine mandates do work, and we see a lot more people getting it. And then I think what also helps people is meeting them where they are. Some governors are going around, I believe it's the governor of Arkansas is going around doing almost like fireside chats, meeting with people, talking with people, understanding what their concerns were and having their questions answered. Because when you understand certain things, I think more people are willing to get the vaccine if they have a notion about, its dangerousness to a certain extent. And then the rising threat, like I said before, I think that is probably the number one thing. People are seeing, hey, it's coming back. And that definitely is driving people. The last thing I'll mention is that you have to also use it to play, essentially, if you want to go to restaurants and travel. And vaccine mandates have been in place to travel to many other countries. If you go to South America or to Africa, you have to get the yellow fever vaccine. And so I think as people want to go out and travel and participate in activities, that's also going to be a reason why they're motivated to get the vaccine now.
Thank you very much. And you listed a number of strategies. Those strategies have to do sometimes with public health. And what has come into the spotlight recently as a result of COVID-19 is the field of epidemiology, and it has been this way like never before. So epidemiologists are crucial in helping us understand the fight COVID-19 pandemic. Yet many people do not understand the field and its role. And so this question is for Dr. Mondesi. What is the role of an epidemiologist, and how important are they in the field in helping us survive and end the pandemic?
Okay, so first I will start off by talking about public health more broadly, that it really focuses on health promotion in communities or in populations where we live, work, and play. And The difference is if you think about medicine, if you go to the doctor, you are treated as an individual. And that is different with public health, where the focus is actually on a population or on a community. Public health in itself has different fields. So for example, health behavior, healthcare organization and policy, and epidemiology, to name a few. Epidemiology specifically focuses on the distribution of diseases or health conditions within populations. And that's the important distinction. So as epidemiologists, we're focused on tracking disease. We're actually very much interested in the who. So who we're actually studying, the what, the focus, so what disease it is, where, the actual place, when, the time, and why. So the why would be what we're trying to get at. Why are we actually doing this investigation? And traditionally, epidemiologists have been called disease detectives. So more specifically with COVID-19, infectious disease epidemiologists were the ones who were very much on the forefront and heavily involved in studies tracking COVID-19. So where it started, how it progressed, and also making predictions for the future. So in particular, infectious disease epidemiologists work at the state and federal levels as government employees and are involved very heavily in this COVID-19 research. They do not work in a vacuum, however. They work alongside other professionals, other scientists, such as pharmacists, physicians, psychologists, etc. And they work to design studies and to conduct research, as with our case with COVID-19, to find out what works. And we know now that masks work, social distancing works, and vaccines work. So that is actually the result of the studies that were conducted with the help of epidemiologists. So that in a nutshell is what epidemiology is about and how it's connected to helping the fight with the COVID-19 pandemic.
Thank you very much, Dr. Mondesi. So Dr. Mondesi listed how epidemiologists are helping to fight the COVID-19 pandemic. And this question is really for Mr. Mitchell. In your line of work, what measures are being taken to ensure vaccine equity and access in Black and Brown communities? Earlier, Dr. Smalls mentioned messaging strategies. What would be an effective messaging strategy in encouraging COVID-19 vaccine acceptance into the Black and Brown community? And also, Dr. Mondesi mentioned that epidemiologists do not work in a vacuum. They sometimes work with the government. So on a federal and state level, what can be done to ensure vaccine access in our communities?
Okay, well, I'll try to get all these questions all in one big swoop. All right. In terms of messaging, I think the key piece is that we have to be honest and accurate. When you're dealing with COVID-19, unfortunately, and it was already earlier mentioned, you're dealing with a lot of misinformation. And so the first thing we have to do is dispel a lot of these myths and misinformation. So that means we have to be completely accurate and communicate that accuracy and to the public. The other piece, I think, in terms of a messaging strategy is that we need to have messengers. And these got to be individuals, especially when you're talking about these communities, they got to be individuals who are trustworthy in those communities, people who know the communities, people who have have spent their time in the communities and who community members know as well. For example, a lot of our religious leaders, some of the local organizations, key members who can provide the right message to the community at large, and who can be very supportive in ensuring that the approach that we take actually can work. In terms of the federal government, I think you kind of have to look at it from three perspectives. First of all, the federal government has already assisted in by ensuring that we have access to the vaccine, and that's from the initial purchasing of the vaccines. Those vaccines then are sent over to the state, who then redistributes those vaccines to healthcare providers, who can then at that point partner with local community organizations to identify pockets in which the vaccination rates are low, and then we can then instill submissions that will get us into those communities and try to increase the vaccination rate. So it's kind of like a two-pronged approach. The message has to be clear. It has to be accurate. It has to be built on science, right? So that it kind of defends against that misinformation. And then the second part is you have to have the people who the community members know and believe to provide that message. And then you have to have the resources there in the community, not necessarily having the community come to us, but we go to the community to make sure that they have the access to get the vaccines.
Thank you very much. And with that being said, there is a lot of, this question is for Dr. Smalls. There is a lot of misinformation in our communities right now. Individuals about it, whether it be about the vaccine, whether it be about COVID-19, and this had led many individuals. The initial messaging was that once you get vaccinated, you could go back to living your normal life. You could have a hot girl summer. You could do whatever you want. And so people got sort of like easygoing, and they forgot that we were in the middle of a pandemic. And so now we're seeing many breakthrough cases. So can you explain what a breakthrough case is, and why is it that fully vaccinated people can still get COVID-19? And why are we seeing such variants such as the Delta variant despite having the COVID-19 vaccine?
So breakthrough cases are when you have been fully vaccinated and you still get a COVID infection. And the reason why you have breakthrough cases is for two primary reasons, which lends itself to how the immune system works. So with a vaccine, the purpose is not to 100% prevent you from getting the virus at all. Is to prevent you from getting very, very sick from the virus if you are exposed and become infected. That was the measure that all of the companies used to determine how effective it was. Some vaccines can virtually protect you from ever getting infected, but the nature of the coronavirus is that it mutates very, very well and very fast, like some of the other viruses that we're used to, like the flu. And so one, vaccines are to prevent you from getting sick, but two, viruses are, the whole purpose is that they have to mutate and survive in your cells because they can't survive outside of your cell. And so they have to be very smart and keep changing. By the time your body recognizes it, they have tried to figure out another way so that they can stay in the cells or infect the cells. So we have now these variants that are getting better and better at infecting us. And right now the vaccines that we have are still very good at protecting us. But the biggest concern that people have or scientists have is that eventually we can get a vaccine, a virus strain that is super, super good that our vaccines don't currently work for, or that we can't figure out a vaccine for, almost like HIV. I don't think that'll be the case here, but it is mutating. We have lots of variants, and we just are trying to keep up with it and preparing for the new variants as they come.
Thank you for that. And I have two follow-up questions.
Mm-hmm.
The first one is, can you get COVID between doses? So if you get your first shot today and maybe 3 days later, you end up getting COVID-19 before you could get your second dose. Is this possible?
It is. In fact, I saw a patient today where that happened to her. And a lot of times we're actually thinking you were probably infected with COVID before you went to get your vaccine. But the thing is that the vaccines take a few weeks to start working. Your body has to recognize the vaccine and start building up its immune defenses. So it's not until 2 weeks after your last dose of the vaccine, so 2 weeks after your second shot for the Moderna and Pfizer, and 2 weeks after your single shot for the Johnson & Johnson vaccine, that you are considered fully vaccinated. And during that time, you are still more vulnerable to getting infected.
Thank you very much. And I like that you said that, because I believe a lot of people still think that as long as they get the second dose of whether it be Pfizer, Moderna, AstraZeneca, then on that same day, it's like they're fully vaccinated. But it's 2 weeks after you're getting your second dose. That's when you're fully vaccinated. And if you take the J&J, then it's 2 weeks after getting the only shot. And I still have a follow-up question, which is, if individuals were not previously vaccinated, but they got COVID-19, can they still take the vaccine, and how long after getting infected should they take the vaccine if they can?
So you can definitely still take the vaccine if you got COVID-19, through natural infection, and you should, because data shows that the immune response that comes from a vaccine is longer lasting than from natural infection in the case of COVID. However, if you do get COVID, you should wait about 3 months until after you've been diagnosed to get your vaccines. And that's because your body already has some natural defenses it's built, primarily the antibodies, and the antibodies are going to attack the vaccine before it even gets a chance to work in your body. So you want the vaccine to have a chance to really work and be as fully effective as possible, but your own body is going to even try to fight that. So after about 3 months, your natural antibodies start to wear off, and then the vaccine can start and take over and start making new antibodies and T cells and things like that fight the virus.
And thank you for that response. And I'd like to shift gears now to Dr. Mondesi. We now know that there is so much misinformation, and we keep saying that over and over and over, but there is so much misinformation out there. And we as scientists knows that science is forever changing and it's forever evolving, but yet to the average individual or to the general public, it seems like science is fixed and unchanging. And with that being said, some of the research on COVID-19 is now occurring in real time and relies on statistical methods to make predictions which may not always be accurate initially. As we could see with COVID-19, we feel like there's always a shift and a change. Either we wear the mask today or we do not wear it tomorrow. And so in layman terms, Dr. Mondesi, can you explain how and why this affects the way in which information about the COVID-19 pandemic and vaccine can change? And I have a follow-up question to this.
Okay, so one thing that's important to know is that it's been about 1.5 years since we've actually been in this pandemic. And when the pandemic started, we had limited information. And for us as epidemiologists, information is data. So with the information we had at the beginning, that is all we had. So we had to use what was available to us and to analyze that data. Based on that, so for example, at the beginning, we were getting data from different states, but the pace was different. So some states released data a lot faster than other states. And so we were, in a sense, just working with what we had. So with that, there is a certain level of uncertainty in terms of whatever results we're getting. However, given the nature of COVID and how serious it is and was, decisions still had to be made based on the limited data that we had. So for example, like you said, Dr. Williams, initially there was this recommendation or lack of a recommendation for wearing masks. So masks were not recommended at the time. But as data was analyzed, or we had more information, we found out that masks actually work. So for example, for us, in terms of data, we're looking at data on race, age, sex, gender identity, as well as number of cases, number of hospitalizations, where people live. And that is how we were able to see over time that individuals of Black and Brown communities were disproportionately affected compared to individuals of white communities. And so as we got more data, it meant that we're able to have more information to unpack, essentially. So we're analyzing more data. It means that our conclusions can actually change. Our results might be different. And so it's important that the general public is aware of the fact that with time, with more data, with more information, things essentially change. It doesn't mean that what we said previously was necessarily wrong. It is what we knew at the time. And I think that's what's important to know, that there may be changes as time goes on.
Thank you very much. You explained that so beautifully, and you should be like the press manager for the CDC, because they do a horrible job at, bridging the gap between science and what the general public is understanding. And so that follows up to my next question, or my follow-up question for you, which is, how do you suggest that researchers and scientists alike better communicate the science to the general public in a way that reinstates confidence and help us fight the pandemic?
So with this in particular, I think as scientists, as epidemiologists, when we speak, we tend to become really passionate about what we're talking about. And what happens in the process is that we use a lot of technical language, our own jargon. So if I'm speaking to another epidemiologist and I use this jargon, they can understand. However, if my audience is different, they may not understand. So I think it's really important that we have to be really cognizant of who our audience is. We need to use culturally appropriate language, and we have to also be mindful of sensitive groups. So for one thing that has happened in the past is that scientists and researchers, physicians have actually worked with members of the community, so community leaders. In particular, when the vaccine was being introduced to the general public, researchers and scientists made connections with faith-based leaders. Faith-based leaders are actually very important within the Black community. And Black congregations have a lot of trust in faith-based leaders. So the faith-based leaders were able to meet with the scientists, researchers, physicians to get this information and then relay it to the members of their congregation, because that trust is already there. So they're more likely, so the Black congregations, for example, are more likely to be receptive to this information. I think one more thing that's probably important is, if we are to go into Black and Brown communities, it's important to consider who is delivering the message, right? And I don't think it's necessarily as simple as saying, okay, we're going into a Black community, so a Black researcher or scientist should approach the public in that case. Because we have to remember too that we, as researchers and scientists, also come, even if we are Black or Brown, we also come from a place of privilege. And so the members of these Black and Brown communities may not identify with us necessarily. So we still have to meet them where they are. So I think it's important for us to also consider that context.
And thank you very much. And just to put a plug, this is why we initially had this show in the first place, because Dr. Myers and I, while we were sitting in rooms analyzing data, talking about COVID-19, we realized that there was a disconnect and that this information was not being well received in our Black and Brown communities. And so we figured, if we created a platform like this with everybody who look and sound like individuals who we want to, reach out to say, hey, go and take the vaccine. And we always ensure that when individuals come on our show, we ask them to speak in layman terms. Because like Dr. Mondesi said, there's always that disconnect. And when you're talking to your friends or when you're talking to your other scientific friends, you'll talk about all of these high level kind of stuff, but that doesn't necessarily translate into to the general public. And the general public, I can remember seeing an article, or if you guys know Dr. Uche Blackstock, where she was saying that even though she is Black and she's a voice in the community, people were still looking at her as a sellout. It's like, you're part of the problem, you're part of the system, why can we trust you? And so there's a lot of things that goes into ensuring and building trust. And that trust in the community doesn't just happen. There's been years and years and years and years, centuries of why Black people do not trust health systems. And so I'd like to turn this question to Mr. Mitchell, and so that we could talk about this debate about vaccine hesitancy and lack of access in Black and Brown communities. Why is there likely to be vaccine hesitancy among Black and Brown individuals? What factors contribute to the lack of access in our communities? And I will ask you a follow-up question thereafter.
Well, I think the first component as relates to the hesitancy has to be relating to mistrust in the government around medical research and sort of the history of unfair treatment as it relates to the Black and Brown community. I mean, I specifically think most often of like the Tuskegee experiment, where, you know, Black men were basically used as guinea pigs to kind of see what the effects of syphilis is on long-term effects. And so when you take some of that historical perspective, it makes it, you know, really challenging to now just all of a sudden forget all this and now kind of listen to what the government is saying regarding COVID-19, the vaccine. I also think, and we've talked a little bit about this earlier, is there's still that perception of racism as it relates to healthcare. Specifically when you're looking at it from the balance of the insured versus uninsured, right? And so that there's a sort of a disconnect or a disbalance between someone who's uninsured and their access to quality care versus someone who's insured. And so I think that, you know, you take those two combinations, and then if you add into the fact that, you know, with all this misinformation, there's a perception of harm for taking the COVID vaccine, and the lack of understanding of the effectiveness of the vaccines, you sort of kind of get yourself a global hesitancy thought process, right? You know, they're asking you to take something. I know that a lot of times it's not true. Then all of a sudden, you know, I hear all this information, and we talk about the Nicki Minaj scenario. And so that's a fear factor that's kicked in. And then I'm supposed to kind of just remove all of that and just go right in and take the vaccine. So I think when you kind of bring all those things together, it really kind of brings that hesitancy.
Thank you very much. And I like that you said this about all of this misinformation is actually causing people to be, you know, more or less vaccine hesitant, and people do have their concerns, and we understand those concerns. And now I think more people will have concerns because now we're seeing that the booster vaccines are coming up. And so this question is for Dr. Smalls. Why is it that immunocompromised individuals require a booster shot? And can we anticipate this booster shot being available to the general public?
So immunocompromised people need a booster shot because when they get the vaccine, their immune system isn't as strong as it should be. And so it does generate a response and can protect you a little bit against the virus, but it doesn't have a very strong protection. It doesn't make as many antibodies or B cells or T cells, and not to get into all the biology about how that happens, but like think about HIV, where you don't have some of the cells in your body that are used to fight infection and also to make an immune response. If you're on immunosuppressive agents as well, you're trying not to have your immune system, like if you're on steroids, medication, so that if you have maybe lupus or if you take steroids for COPD or for any other reason, we're preventing your body from responding normally. So when you get the vaccine, it just won't be as strong. The FDA yesterday recommended that or authorized for the Pfizer vaccine booster shot to be given for people that are over 65, for people that are more likely to have a severe consequence of the disease, including people that are immunocompromised or have other medical conditions like diabetes, obesity, asthma, COPD, whatever. And they also recommended it for certain healthcare professionals or people that are at high risk of exposures, whether that be firefighters or teachers. However, today, the CDC, which makes the decision on who gets vaccines, it ultimately lies with them. The FDA just says, hey, this medication or this vaccine is safe and you can use it in this situation. But the CDC makes a decision, okay, it will be used for these people in this situation. They said that the vaccine will be authorized for people over 65 and those that have chronic medical conditions that put them more at risk, such as people that are immunocompromised. However, they did not recommend the vaccine for people that are more exposed to coronavirus. So like nurses, people working in healthcare. So that's the difference between them. But right now, they expect that tomorrow you can go, whether that's to your CVS, Walgreens, or other state-run facilities, and be able to get that booster shot if you are in those categories. So that's very exciting news.
Thank you very much for that. And the follow-up question is, because of the booster shots, does that mean that the efficacy of the vaccine goes down as time progresses?
Essentially, yes. That's why we are getting the booster shot. And this is not a failure of this vaccine. A lot of vaccines require booster shots. It's a consequence of just how the immune system works. You have antibodies, that's the thing that everyone thinks about, and those hang around in your body for a couple of months. And then you also have T cells that also fight infection. And then you have like memory B cells and memory T cells, and these can stay around for months to years to even decades. But for every type of virus that you have and vaccine that you have, it generates a different response. And what the data is showing is after about 4 to 6 to 8 months, depending on what vaccine you get and what they measured, that your immune system is starting to wane. They're mostly looking at antibodies, but you have fewer antibodies in studies that have come out of Israel, primarily, where a lot of people are vaccinated with one vaccine, have shown, hey, there are a lot of breakthroughs after a certain time, even though all these people are vaccinated. So it's not a failure of the vaccine. This is how things work. We get flu vaccines every year. We get boosters for, Tdap, for many other diseases as well. So the vaccines work, and this is just the next step.
Thank you very much for that. And I just want to switch gears just a little, and this question is directed at Dr. Mondesi. The year 2020 was an unprecedented year. Not only did we have COVID-19, but a lot of the structural racism that exists in a society against Black and Brown people, it just came to the spotlight. And so a lot of medical organizations were challenged during the year 2020 to stand in solidarity and to actually profess that Black lives do matter. And one of these organizations was the American Public Health Organization that said that racism is actually a public health crisis. What does it mean that racism is a public health crisis, and how important is this in the movement to advance racial and health equity and justice?
So I think it's important that we first contextualize this. So with racism, we know that one group has an advantage versus another group with a disadvantage. And we know in the US that Black and Brown individuals are at a disadvantage, right? So with this anti-racism movement, we came to find out that, all over the world, there's this push towards improving the health and essentially the well-being of Black people. So what it really means in declaring this as a public health crisis is that they're now acknowledging this as being widespread, that structural racism is pervasive in society and it affects everything. Many of us have experienced racism in some form or fashion, even if it is a centuries-old problem. And with the COVID-19 pandemic, for example, we saw that also come into the forefront in terms of the number of lives that were lost. And I think one thing that's especially important now is that with this, we actually saw a tripling of the COVID-19 deaths when you compared people in Black and brown communities to people in white communities, right? So there was a almost 3 times higher death rate. Additionally, one thing that's important to note is that with this stressor, so racism is actually a stressor. So it's a toxic stressor and it happens over time. Therefore, it's chronic. So as it happens over a lifetime, this can actually lead to not just psychological changes, but what we call physiological changes. And physiological changes are actually changes within the body. So the body adapts essentially. So that can manifest as accelerated aging. It can also manifest as chronic diseases, as Dr. Smalls mentioned, for example, diabetes, obesity. These actually put individuals at higher risk of severe disease from COVID-19. And additionally, the mind also adapts, like I said, with the psychological changes. So with these changes, individuals tend to adapt what we call coping mechanisms, which may actually end up being unhealthy. All right, so in essence, racism just trickles down to these poor outcomes. So we end up being sick, and it also may lead to premature death. So in other words, the life expectancy of Black and brown individuals is actually lower than that of white individuals. And we see that all the time. And in particular, I think it's important that we continue to make that connection, that definitely racism is something that continues to affect our communities. And I know now we're specifically focused on health, on COVID-19, but it is something that is pervasive, as we know, in every aspect of the community.
Thank you very much for this. And that was a very good response, and that was a very good way of explaining it. One of the communities or one of the populations that often go, that's lumped, for example, Afro-Caribbean individuals are sometimes lumped into African Americans, and there's so much difference between those. There are differences between that community, but oftentimes we get immigrants being lumped into that population all the time. So we tend to forget about the immigrant population, even though they make up a significant part of the American population. And so immigrants, especially those who who are undocumented, they have this fear of just like, African Americans and Hispanic individuals, they do have this fear about the health system. And so we need to be able to reach this population in order for them to get vaccinated. And so what community outreach efforts are being done to target and reach this population? And this question is for Mr. Mitchell. And I specifically want to say that when we go to get the vaccine, we're often asked for our insurance. Undocumented individuals do not have insurance. So what would you say to an immigrant who wants to get vaccinated, but there's all of this fear surrounding getting the vaccine and probably documentation?
So I think you got to look at it in a couple of ways. So in terms of individuals, immigrants from different populations, the one thing that we try to do is we actually bring the vaccines to them. So that fear factor of coming into an institutional environment is kind of removed. We use our mobile units, and we also partner, which is the key factor. We partner with our with organizations in those communities who knows where those pockets are. And then when we partner with them, it holds basically two support structures in one, right? You have people who know those individuals, who can communicate with them and kind of explain to them it's safe. And then you have another entity that's in there to say, we're here for you, and we're going to provide you something that's going to allow you to continue doing what you need to do for your family and things like that. So I think that's one piece. The insurance part, I think, it's really not necessarily geared towards specifically in the immigrant population. We insurance companies are mandated to support COVID-19 treatments. And that also includes vaccinations. And so a lot of times when we're requesting insurance information, it is to submit for claims, but it's not necessarily to provide some form of documentation that can be utilized in some other manner. It is strictly a claims-based scenario where we're going to ask the insurance companies to cover the costs that they're mandated to cover. And if the insurance companies, for example, chooses not to because the information is incorrect, then we don't go after or go seek that money from the individuals. We just basically write off, because the goal is really the shots in the arms. But if the insurance companies are obligated to cover that, we're going to seek those reimbursements, because it helps offset the cost that we're incurring as a result of doing so many of these activities.
And thank you very much for this. And earlier we gave individuals information on where they could get the COVID-19 vaccine. For those in NYC, you could visit nyc.gov, COVID-19 vaccine finder, and you could always visit northwell.edu. This is a plug for our organization. Always visit northwell.edu and you will get access to everywhere that Mr. Mitchell has, the mobile buses that goes out, and how we do our community outreach, not only in Long Island, but Mr. Mitchell, correct me if I'm wrong, we do have certain places in the city. I remember last year we did have
we're all over.
Brooklyn.
We're in Brooklyn, we're in Queens, we're in Manhattan, we're in Westchester. Basically, wherever there's a need, you can count on Northwell to be there to support our communities. The other thing I would also say is that we also have a phone number that people can utilize, which is 844-919-VACC. That actually leads them to operators who can then help them also in terms of, if a person doesn't have the ability without any to make appointments via computer, our operators can support them that way.
Thank you. And this is, as Dr. Myers has some technical issues, so I'll allow her to settle down and have one more question that I'll ask Dr. Smalls-Mantee. And this question is that recently the FDA put out a statement indicating that ivermectin should not be used to treat or prevent COVID-19. Last week, Arizona's largest health system warned the public against using the anti-parasitic drug to treat or prevent COVID-19. What is ivermectin, and why shouldn't the general public be using it and other drugs to treat and prevent COVID-19? And what are the FDA-approved drugs for treating COVID-19? Are there any drugs to prevent COVID-19?
Like you said, ivermectin is a drug to treat parasite infections. It can be used in humans to treat scabies and head lice and infection with strongyloides and river blindness. I mean, two individuals got the Nobel Prize in 2015 for discovery of this drug. So it is very, very important. However, it is more commonly used in treating animals with parasite infections, with dog heartworm and other animals like cows and horses, and that is how people are accessing it. Ivermectin is more available to those individuals as a prescription for their dog or their cow or their horse, and that is a very, very high dose of the medication. So in high doses, that is lethal to people. In lower doses that humans take, it is not, but it is it paralyzes the tissue of of the parasite. And when humans take it in large doses, it can cause paralysis as well and death. So that's why we are being told it is not indicated for humans to treat COVID-19. There are not any robust studies that show that it is effective for that. However, there are several treatments available for people that have mild to moderate COVID infection. And those are the antibody cocktails that we've heard of. There's the Regeneron antibody cocktail. There's remdesivir by Gilead. Actemra is another one. So there are antibodies available. You can either get these infusions as an outpatient. Some of them are more so indicated for if you are admitted to the hospital, but those are the FDA approved or FDA authorized treatments for COVID. There are no treatments to necessarily cure you or, magically of it. It's not like an antibiotic, but it can reduce the course of your illness. Right now, the only preventative measure that we have against it, or the best one that we have, are the vaccines.
Thank you so much. I greatly appreciate that. This was a really wonderful panel. I want to say thank you to Dr. Favo Mondesir, and congratulations, by the way, on your American Heart Association Fellowship. I also want to thank Mr. Mitchell Cornett, as well as Dr. Adjua Smalls-Manty. There was a lot to be learned from today's session. If you haven't been vaccinated, there's still time to get vaccinated. You can look on either the Northwell website or nyc.org, or check with your local pharmacy, whether it's a mom and pop pharmacy, Rite Aid, CVS. They all have been, Walgreens, they've all been giving vaccines. We learned today what epidemiology is, and I think Dr. Mondesir did a great job of saying pretty much their job is to track diseases and disseminate information about diseases to the lay people. And it's important that not only that we deliver these messages, but we have messengers. We've heard from our multiple panelists that messengers from religious communities and messengers that look like us are most effective in spreading the word in the news about COVID. And we also know that if you've gotten COVID, it's very important that you, if you're having symptoms, you can get these monoclonal antibody infusions. Northwell, we have it. So you can talk to your primary care doctor. They have sites throughout our health system where people can come in. I know for our facility, if you've gotten that, you have to wait 90 days to get vaccinated. However, if you haven't been treated with monoclonal antibodies, we will routinely vaccinate people 10 days after they've tested positive for the COVID vaccine. And of course, we do use the PCRs in the hospital, not the rapid testing when we do the testing. We also know that there's antibody testing, but just because you have positive antibodies, we're not saying that you should not get vaccinated, because studies have shown that vaccinations after having COVID actually boosts your immunity. So we still would recommend doing both. We also know that unfortunately, historically, our government has done some things like the Tuskegee experiment, as Mr. Cornett mentioned, but I've been speaking to a lot of people who don't even blame Tuskegee at this point. They actually know personal things that they've experienced in healthcare, more recent, even though most of us on the panel know that Tuskegee wasn't that long ago and it just really ended in early 2000. Serena Williams is a prime example of something that's more recent, where a woman of color went and said, I think I'm having a blood clot because I've had one before, and she did not listen and she had to fight, and sure enough, she did have a pulmonary embolus. So I think Tuskegee is one of many unfortunate events that have happened to people of color in this country, and a lot of people have experienced their own personal things on top of that. And it's really important that we as healthcare providers be cognizant of this, and we are sensitive to this when we have these conversations with people in communities of color. And last but not least, I just want to leave you that our next show will be happening on December 7th. We know that October is Cancer Awareness Month. So I just want to share with you that we will have the esteemed Dr. Janet Andrews, who's a radiation oncologist in our Northwell Health System, as well as an associate professor in the Zucker School of Medicine, as well as the also esteemed Dr. Jacqueline Barrientos, who is a hematologist oncologist in our health system, as well as an associate professor. We look forward to having a great discussion about breast cancer as well as blood cancers. Please join us then, and shout out to Remote Chess Learning, which will be our community host. On behalf of both Dr. Maya Williams and myself, we thank you for tuning in to another episode of Corona Conversations in the Black and Brown community, and we look forward to seeing you again in 2 weeks. Take care and have a great night.
Thanks, everyone. Bye.